Greetings, everybody. We'll just give a few minutes for some of the participants to join in. My name is Mamta Shah, and I'm going to co-host it with Orlando Flores from Quanacum, Chile, and I'm from Manchester in England. Welcome to the World Burns Week webinar series. For those of you who prefer to listen to this in your own language, could you please go to the closed captions, click on it, select the English language, which is your speaking language, my speaking language, and then select your own language after that, so that you can listen to it in your own language. Thank you. There will be more instructions in the chat. Okay, so this evening's webinar is on protecting childhood futures, changing minds, and preventing burns. As you all know, a large proportion of the world's population that gets injured is children, and most of those injuries are preventable. It is very important to prevent those injuries, and you're going to be hearing from a panel of very good speakers this evening. The first speaker is going to talk about why it is important to prevent burns in children, and the subsequent experts from Chile, Nepal, and Mongolia and England who have done work in Mongolia are going to talk about what we can do and what their experiences are. So our speakers today are Claudia Murungi, who is a burn survivor and activist. She's going to start the webinar today and present her experiences from childhood to young adulthood, the challenges that she faced, and what she did to change a bad experience into a good experience. This will be followed by Carmina, who is here with us this evening, and she is going to be talking about her experiences of preventing burns and the framework that she uses in Chile. We will then hear from Regina Shilpaka, who is a burn surgeon and deputy medical director of Sushma, and also she is the area representative for Interburns. And finally, we'll hear from Professor Patricia Price from Wales in the UK. So without further ado, let's hear from Claudia.
Hello, everyone. My name is Claudia Murungi. I'm a burn survivor and an activist from Nairobi, Kenya. I'll be sharing my story today about life as a survivor, how it was before, the experience during the fire, and even life after. Just give me a second, kindly. So, I was in a fire when I was very young. I was 13 years old. And at the time, I'd gone for a school trip after finishing my primary school education. So it was very, very exciting. It was a gift from my dad. So that was going to be the first out of town trip for us. So I was very, very excited again. I'd never been out of town. I'd never slept out of home. So I was feeling like I've now become a big girl, and I was very, very excited about it. So once we got there, it was just a normal trip. Everything was fine until we got to the hotel where we were staying at. At the hotel, there was a food warmer. So we were queuing for dinner, and there was an open flame. So once I saw the chef was trying to fuel the food warmer, I didn't think anything about it. I mean, I saw some fire, but I didn't think anything about it. I just thought it's normal. This is professional. He's done this 1,000 times before. So for me, I was very confident. I didn't think of it as a dangerous situation. I felt no need to panic. So now, however, though, when he was continuing to fuel it, it accidentally caught fire. And unfortunately, because I was among the first people in line, I was very, very close to him. The fire spilled on my face. It was the liquid. So the liquid spilled on my face, it spilled on my forehead, on my eyes, on my ears. And then actually, as we can see, that was literally the beginning of everything. It was the beginning of my new life. At the moment, I remember I was like that was I think the slowest 2 minutes of my life. Everything was moving in slow motion. I could feel the heat. But it felt surreal. I didn't believe I was actually on fire. And I think if I had seen it even on video or something, I probably have gotten in shock or something. So immediately after, luckily there were teachers around. The teacher, he poured water on my face and was rushed to the local ER. So there, the local ER, they did some first aid, and after the first aid, I spent the night there for observation. So the doctors monitored me, and then in the morning they decided I'm going to fly back now to Nairobi for specialized care. And from then I met a plastic surgeon. I met a guidance and counselor. My parents were also waiting for me in Nairobi. And so from then, that's when, so slowly, I'm noticing things are changing. I'm noticing, okay, how my classmates were acting, how my teachers were also acting. The fact that I had to be flown to Nairobi, I went to Kisumu through bus, but then I'm flying back to Nairobi. So if this was just a normal accident, all this wouldn't have had to happen. So I also started taking mental notes of what is happening, how people treating me. So even before my parents were allowed to see me, they were told they had to go and see a counselor. They had to talk to somebody to tell them not to be so shocked or so surprised when they see me, because if I could read it in their faces, then I'd probably worry a bit more and I'd become more anxious. So once that happened, my parents came in, and eventually after some counseling, after they received their first counseling, they came in and they saw me in Nairobi. And I was able to see now a plastic surgeon who we did a bunch of surgeries. We did continuous plastic surgeries on my face. I had keloids and they treated them and they tried to make them as small as possible. They tried to make my face go back to as normal as possible. So within 6 months we were done. But then by the time we were done, I remember the surgeon, he told me, Claudia, this is our last session. And I felt very empty. I felt like I was left floating in space. Like, okay, we're done. We've been talking to you. You've been asking me how I am. But I've never, like, what am I going to do now? Because I was seeing the doctor every Monday. So now that's when he recommended for me to see a counselor. And the counselor was able to talk to me and it was a bit better. She started telling me, the first thing she told me was that my life has definitely changed. Things are different now. Like, I am still beautiful, but I also need to mentally tell myself that my life has changed and that things are going to be different. I need to now approach life from a different point of view. So at that point, my parents also decided to switch my schools so I could sort of have a new beginning. So I could also not feel the pressure of my former classmates coming to see how does Claudia look now? She looks a bit different. And so after changing schools, things were a bit easier, although I really recluded back into myself. I didn't have such a high self-esteem. I was very triggered by even the smallest conversation. And children are bullies. So for me, I struggled a bit, especially the first 1 year. And then the second year, I also struggled a lot. But it got to a point where I decided, really, this can't keep happening. I was such a young age. How could I allow myself to continue to be sad forever? I wasn't okay. I wasn't happy with it. So physically, I was healing. Physically, everything was magnificent. The surgeon was saying I'm healing well. I'm having a good diet. I'm hydrating. I'm eating the fruits. So physically, I was fine. But emotionally and mentally, I was alone for a bit. But then that's when so even my grades started failing. So I had to tell my dad, I had to tell him, hey Papa, like something is wrong. I'm not fine in school. I feel I don't have friends. I'm afraid of talking to people. And after that, so that's when we now decided to get another counselor in school. And the counselor, she talked to me. She told me that things would be fine, that I'd be okay, and not to worry so much. But I also had to also now do something practical about it. I had to get out of my mind, for lack of a better word. I had to stop thinking about it so much. I had to find other things to sort of make a priority. So I started joining clubs. I also joined the local church group, the Christian Union. And after that, things started getting better. When I was in Form 3, there was a new girl who was in Form 1, and she joined, and she was also very insecure. I remember when I joined at some point, I had to wear a headscarf because I was very insecure. I didn't want people to see me. I just wanted to disappear. I didn't want to be noticed. I'd forgotten myself, for lack of a better word. So after a while now, once I joined the communities, the Christian community was very supportful. The church group, the Christian Union Also, I joined Scouts, I joined Rangers, I joined, I think, Home Science Club, where we'd learn how to cook also, because I'd also been really, really terrified by fire after my accident to the point where I couldn't even go into the kitchen. But after that, after finishing high school, I think I sort of, I got out of my head. I created things to look forward to. I created other things that were not just my face. I worked on my personality. I worked on my talents. I worked on my skills and also religiously. So that really, really helped. So by the time I finished now, again, initially I'd always wanted to go into modeling. And for a point in time, I had forgotten that dream. I told myself, okay, you can't do this. I'm going to go into sciences or something that does not really require you to be physically there. But deep down, I still had my personality. I was still very, very outgoing. I still wanted to express myself through my dressing. So I started slowly. I started with, I joined uni, and in university, I started with my friends. I had friends who had cameras, and we'd do small photo shoots. And with time, I gained traction. I started having deals with organizations. I started having deals with fashion designers, and they would choose me specifically and intentionally because I had scars. They said that was what was unique about me. So I started seeing my scars as my strength. I didn't feel secluded by them. If anything, I felt like my scars made me stand out as compared to if I had not had scars, I'd still be a model, most likely, but I wouldn't be the model I am in this unique way. So I got a chance to be a model, not just physically, not just for clothes, but also for burn survivors. So now I think I try my best every day to be an advocate for burn survivors. And I think the 13-year-old me, what I had wanted. If somebody is now in a fire at 13, I want them to look and see, okay, when you go to Google, you can see there's a girl called Claudia. There's somebody who went through the exact same thing that I'm going through, and she made it out. She was able to overcome the challenges, and now I'm actually thriving. So I also want to encourage burn survivors and their families, their relatives, the people closest. Like, first of all, it's okay to seek help. It is really, really okay. Like, and it's health like anything else. It's just like if you're in a car accident, you go for physiotherapy. If you go through an event and if you go through an event and it affects you mentally, seek the mental help. If it affects you physically, seek the physical help. And I'm so, so glad to be a part of Interbands because I can see even within the last 5 years how much progress we've made in terms of normalizing burns, in terms of desensitizing people, and just making burn survivors feel like, okay, it's just another accident. It's not something you did wrong. It's something that happened to you. It can happen at any age. So again, I really, really encourage people to seek help, seek community, and try and be your brother's keeper. When you see somebody who's been through something like that and they're trying to shy away, talk to them, guide them onto counseling, show them that life can be normal and that it can continue. So thank you so much, everyone. Yes, I'm Claudia again from Nairobi.
Thanks, everybody. That was a very powerful message from Claudia, describing why it is important to prevent burns in children and the impact it has, and the changing impact it has over life, the course of the years, and it is okay to seek help and turn your life around. We are now going to move on next to Carmina Domic, who is who's going to introduce herself. She comes from CONACEM in Chile. It's an NGO organization that treats children with burn injuries. Carmina, thank you.
Thank you very much, Mamta. Hello to everyone. Thank you for the kind introduction. It is an honor to be here today and share some of our work in Chile at the Corporación de Ayuda al Niño Quemado, known as CONICEM, a non-profit organization dedicated to the comprehensive and rehabilitation of children with burn injuries, and dedicated also to prevent these injuries and to do teaching and research in the specialty. Over the next few minutes, I would like to talk about what is important to consider for designing burn prevention programs of children and what we have learned along the way. Okay, the first step in any effective prevention program is to understand the local reality, the specific context of the community we want to reach. We need to know how burns occurs in that population, who is affected, at what age, under what circumstances, and within which environmental and social conditions. That means understanding the epidemiology of burns in children, the geographic and climatic context, the living conditions and home environments, and importantly, the cultural habits and daily practices that shape the risk. This deep understanding doesn't come from a single source. There are different ways to obtain this information, and we must add them up. First and foremost is the one we find in the clinical records of patients who consult for burns. There is the evidence available in publications. And no less important is what direct contact with the community bring us. In relation to data need, it is important to mention that it isn't enough to measure at a moment in time. The burns evolution in a population is dynamic, not only their numbers, but also in the way the burns occurs. In the slide, we can see the image of a 10-year comparative study carried out by Koanikem about the epidemiological characteristics of our consultants and their evolution over time. The results show that collecting data at one point in time is not enough. As living conditions and technologies change, so do the causes of burn injuries. For example, the introduction of new heating devices or cooking methods can create emerging risk if people are not adequately informed about their safe as. This constant evolution reminds us that prevention must also adapt and evolve. Once we understand the local context, the next challenge is to choose our priorities, to define the specific group we want to reach and the behaviors we want to change. We cannot address every problem at once. Instead, we must focus our effort strategically and move forward step by step. It is also essential to recognize the unique characteristics of each audience. If our messages are not aligned with their values, language, and way of life, we lose the chance to truly connect. I would like to insist with some examples on the importance of identify aspects of our target audience, since otherwise our messages will not be received as their own and we will not achieve what we are looking for. Climatic characteristics largely determine the causes of burns and the causal agents, as we see in the images. In cold climates, burns are often caused by scalds or contact with heating devices. In contrast, in warm climates, more injuries occur outdoors. Age is another important factor. Young children are typically injured at home, often in the kitchen and bathroom, while adolescents are more exposed to burns through risky behaviors or work activities. And perhaps the most complex layer of all is that the cultural custom and traditions, how the families cook, heat their homes, or celebrate with fire, are powerful determinants of risk. These are often the most difficult to modify, yet they are essential to understand what if we want our intervention to succeed. If I could offer you one piece of advice, it will be this: choose your battles wisely and select your tools accordingly. For example, if your target group has access to technology, use social media campaigns and on-the-ground education. If not, focus on community-based education and face-to-face outreach. Always tailor your materials to your audience. Use playful and visual materials for small children. And let peers communicate with peers when addressing adolescents and native people. Research consistently shows that multiple coordinated interventions in the same community are more effective than isolated actions targeting different groups. So, our effort should be aimed at addressing the same people in different ways, rather than isolate actions in different audiences. Finally, and in conclusion, I'm going to mention 3 points that guide us to continue moving forward. First, improve clinical data system so that information about the causes of burns in patients can meaningfully inform prevention strategies. Second, with the analysis obtained from the information in the previous point, we have to work in strengthened collaboration with other sectors, state, legislators, educational system, policymakers, and others to address the broader social determinants of burns. And last, we need to find ways to systematically evaluate the impact of our interventions and programs using qualitative or quantitative method so we can understand what truly works and where we need to improve. Thank you very much for your attention. And if you want to contact us, please feel free to write to my email or my WhatsApp. Thank you.
Thanks very much, Carmina. That is an excellent presentation. And we will now move on to our next presenter from Nepal. She is the Deputy Director for Surgery, and she's a general surgeon who is currently in Singapore training in her plastic surgical skills. And she's also the regional rep for Interburns.
Namaste. I'm Rojina, and today I'm very delighted to share my experience and how in Nepal we empowered community in an attempt to prevent burn in children. Just like Carmina explained, like it is so important to understand the behavior of community and strategically develop our programs so that it actually works. A little bit about the statistics in Nepal. In 2008, Nepal government estimated that about 55,000 people sustained burn injuries and about 2,100 people die. And out of that, third most common injury is the burn is the third most common cause of injury and disability in Nepal. And what we've noticed over the years, in my experience and my colleagues' experience, is children coming from rural areas, they have sustained more severe burns. It is also the second most common cause of unintentional injury in children below 5 in Midwestern Nepal. The causes, like in every other marginalized and middle income countries, children get burned by hot water when they're playing around the unsafe environment of the kitchen. And we also had many patients who arrived. The mother is carrying the child while cooking, and the child has actually been actually fell down in a big pot of porridge or in a large pot of hot boiling oil, a large pot of milk. So it also shows that there is a lack of awareness of general health literacy among the mothers and the primary caregivers. A lot of children get burned because of the ground level open fires and LPG gas accidents, kerosene stoves, and because of mismanaged electrical wires in our villages, town planning, cities, and also contact burn and chemical burn, but the most common is scald and flame burn. These two pictures of the patients that we treated in my facility, Sushma Koiral Memorial Hospital, it is actually the representation of all the things that went wrong in the safety of children. The first kid that you can see, he actually went to jungle to collect the fodder, and he was playing with matchstick. So he sustained a flame burn injury. His parents thought he was going to die anyway, so he was not taken anywhere within 2 weeks, and the child survived. So they started looking for help, and then when it came in social media, we saw the case and we called the child for treatment. And another kid is an example of many young boys, especially. They also go for cattle grazing in forest, in jungle, and he accidentally got in touch with high tension wire, which was actually installed by the villagers themselves to ward off animals. So this shows that these children were exposed to completely unfriendly environment, and they were given the completely child-unfriendly task. They had to do those activities. This is also because of the lack of awareness of prevention. And when the parents, the child sustains injury, the parents don't know what to do, especially in the rural areas, and they they bring the child late to the facility, and by the time the child will have already sustained very severe injury, and it is too late to sometimes salvage the limb, salvage the life, and even if the child lives with a long-term disability and many more surgeries to go ahead. Small statistics from the facility I work in of 5 years, we can see that out of total number of patients, like even half, like 50% is 45%, 43% are children. In the gender distribution, males seem to be slightly higher. And among the most common cause, scald burn and flame burn are the highest. And children coming inside, from inside and outside Kathmandu, they're pretty much the same, but what we realized were children sustained severe burn injuries who came from outside Kathmandu. So we thought, out of all these problems, prevention is the main treatment. Prevention is the cornerstone to tackle these problems. There are many stakeholders at different levels who are important. So we decided to work at the grassroots level to prevent burns in children, and the sequelae, what we can see in this picture, what happened to this child. So in 2017, Interburns partnered with Sagun, a local NGO which was supported and funded by National Institute of Health and Care Research. And we chose 3 municipalities. Actually, this whole process was in detail presented by our colleague, Dr. Kamal Fial, in the session previously. So I will say in short, survey of 1,279 households were done, and we found out that most of the accidents happen at homes, in the domestic settings, in kitchen, and mostly women and children are getting affected by it. So this project was started with participatory action research involving local leaders, female community health volunteers, burn survivors, and so many ideas from them were taken for data collection, how we can develop a safe environment for children and how to prevent it, how to train people. So after the survey, a package was developed according to the suggestions of the local leaders and the female community health workers, and also the health personals who work in the health posts in the community. And after we develop basic burn care package and community burn prevention package. So within 2 years, we trained 65 primary health workers, 115 female community health volunteers, and 800 plus women's cooperative members and school children. And they were trained in a way with visuals, with discussions, with demonstrations, with posters, and with the magazines, with calendars that show the cartoons which they can relate to. You can see the photo, the women in wonderful blue saris. They are the female community health workers, and they are the strong and the grassroots. They have the robust network that get in touch with mothers and each household in their ward and in their community. So we thought they were the most powerful group to be in contact with, who can relay those education to the mothers. So we empowered the female community health volunteers that they should hold monthly meetings, and they should always speak about and discuss about burn prevention. And what we teach them, they should teach these safety tips during their whole home visits, and encourage neighbors that these safeties should not only be a task or a duty, it should be the way of life. And we distributed burn bulletin calendars, flip charts, and posters to them to be distributed among the children, to be distributed among the mothers and the primary caregivers, because they are the ones who the households in the rural areas really do trust, even for the medical and non-medical advices. So these are the posters, and that we distributed these who they can actually relate to. This shows the children how the kitchen is not a safe place, and how they can train the mothers that they should put a barrier, or for example, while cooking, they should not be carrying a child, and that when even small thing like putting the handle inward while they're away and have just cooked a very hot meal, and put the even cup of tea away, that so that the child cannot pull it. So small changes, we train them to train mothers and the primary caregivers to make a way of life. And after 2020, the impact in our follow-up visit and follow-up survey, we found out that among the 3 municipalities, in 2 municipalities, there had no burn injuries sustained, which we previously found out that there had been about 92 cases in all 3 municipalities. But after 2 years, we found out that 2 municipalities did not have any burn injury cases. And from this pilot project, we found out and we could learn that if tried, if given proper training and orientation, that burn can be prevented. So we started and expanded this prevention program to school children, to mothers group from different communities, and we started training. We also started getting invitation from ward to ward from the female, especially from the female communities, mothers group. We gave them simple lessons like first aid, how to do it when one gets burned, when people surrounding your area gets burned, to stop, drop, and roll, and not panic, and cool the wound first, and not use any other believed first aid modalities like mud and cow dung, or aloe vera, toothpaste, tomatoes, which we normally see patients coming in with. So we taught them very few points, but very basic and important points, and then safely transport them to the hospital. After the success of this program, we also made a lot of proposal requests in the different level of the government, and central and the local government helped us and encouraged us to integrate this burn prevention program into rural health plans. So, and government actually helped us to choose the participants from different provinces, all the provinces all over the Nepal. So we do not just focus on one place or just inside Kathmandu. We teach them, we demonstrate them first aid, we teach them how to do simple dressing, bandaging, and for female community health workers, it's more like discussion. We make them participate and get them to answer themselves that how the programs or how these steps can be implemented. So from all this, what we learned was childhood burn can be prevented if taken small steps in a unity manner, and that it should be integrated into a school education system, which is more important than we'll be directly communicating with the children. And we should there will always be burn no matter how much we try to prevent it. So we should train the grassroots level people, the people who are more in contact with community, the prevention, and even if it cannot be prevented, at least proper first aid and proper referral system, how to refer in the burn care specialist hospitals. And this picture is actually very special because the person who is giving the orientation to the community health workers were the burn survivor herself, who sustained burn injury as a child, and it was an acid attack. But she was brave enough to come through this, and then helped her, encouraged herself to be part of this pilot program, and she was throughout with us during this pilot project. Conclusion and the lesson learned is childhood burns in Nepal are preventable, but multi-sectoral approach should be done. It is a public health crisis, so public health approach is very essential. Prevention saves lives, it is true. And in case you were wondering, the kid in the first picture covered with the cow dung and mud, what happened to him? This kid is him. We managed to save him and give him proper treatment. He went back to school. Thank you very much.
So thanks very much to Regina for a fantastic approach that has made a big impact in Nepal. We will now move on to Trisha Price's presentation, and she's going to talk to us about how even in a remote place like Mongolia, we can have prevention programs that work. So over to Professor Price.
Hello everyone. I'd like to start by thanking the conference organisers for inviting me to be part of this symposium and to apologise for not being able to do this as a live session. We need to acknowledge a number of people who are part of the project, not least the participants. You will see some photographs in the presentation, and I want to assure you that everyone's given permission for that to happen. We did receive some funding from the NIHR in the UK. And technical support was provided by Kathy Miller Studios in providing some of the technical drawings. The biggest thanks, though, has to go to Gerelmar, who is the first author on the publications related to this study, which I'll share with you later on. At the time of the study, she was a PhD candidate, but because she was from Mongolia and spoke the language, she was an enormous help because she knew the context, she knew cultural practices, she knew the importance of traditional methods of cooking, and allowed us to make a wide network of collaborations, partners that allowed the project to be such a success. A bit of background for you. Mongolia is classified as an Eastern European or a Central Asian middle income country with a population of about 3 million. Now, this study took place in the capital where about 50% of the population are based. But there's something particular to Mongolia that led us to want to be involved. A study in 2013 showed that there were about 8.1 per 100,000 children involved in a burn of injury of some sort. Now, when you take it that the mean for all the other countries classified in this group was 1.3, this really stands out. And you can see on a colour coding that Mongolia here is the darkest colour, and it really does focus attention on asking some questions about what is happening here, what is different. Many people in Mongolia live in what we would call Mongolian yurts, but locally are known as gers. These reflect the traditional nomadic style of many people who live in Mongolia. But the thing that's really important from this study's perspective is that there's one living space. Everything happens in this one space. There is no separate cooking area, and everything takes place here. And the majority of traditional cooking happens in what's known as a cooking pot. You can see a picture of a modern cooking pot in the far corner and a lady using it on the floor in the middle of the ger. And even when they're electric, you can see there are often wires across the floors because somebody's literally sleeping in this bed above it. Everything happens in this one space. So this led us to ask a number of questions around whether we could design a practical but culturally acceptable solution to helping to remove some of the risks. Bearing in mind, it's not practical to find a separate space, and the cooking pot is an enormously valuable traditional method of cooking here. The study design that we used involved 50 families that were randomly selected with the help of the local council officials. They had to have a young child living there, be living in a gare and using the cooking pot, obviously, to be part of the study. Now, what we designed, and that did take a lot of background work, was a steel rack that would elevate that pot off the floor. And we provided these free of charge, 75 centimetres high. You can see in some pictures that I'm going to show you how they were used in practice. There was a lower space for storage, so it should fit reasonably well within the size of a gare. We worked with a local set of researchers and trained them to be able to show each family how to use the gare and how to collect the information that we were interested in terms of how we could then evaluate their use of it after both 30 days and then again 10 months later. These are some photographs of some of the families and show you how they were using the gare. In this particular photograph, you can see they've used the rods to keep the pot quite firmly in the centre of the rack, near the two central poles. This particular family divided that top section into a smaller pot, but it allowed them to use the kettle in the same way. This family has put it against the side of the gare, against one of the walls. Now, after 30 days, the person who was responsible for cooking, which was usually the mother, but often was the grandparent, or very occasionally an aunt, was asked to complete a paper-based structured questionnaire, which we had previously obviously developed and piloted. In addition, we asked them to attend focus groups in either local community halls or some equivalent sort of space. The largest number attending was 10. After 10 months of continued use, we then asked the researchers to individually visit each household in order to complete a semi-structured interview. And in both of these instances, the emphasis was on their experience of the rack, things that they thought we could do to improve the rack and make it even more acceptable, and how much they might be willing to pay in order to have such a rack in their household. These are some pictures of the focus groups taking place. This one was in the local library, this one was in a local community hall. For those interested in the technical details, we used R version 3.4.2 for our analysis. There was a qualitative stream of data analysis, which we used with multiple researchers analysing the data on an iterative process, confirming, collaborating in terms of their understanding. Also quantitative methods, particularly for the willingness to pay and trying to rank their preferences for the improvements they'd like to see. And for that, we used the best-worst scaling method in order to give them some ranked priorities. Some details on the participants. You will see from this slide that most of the household had 2 children, but here is the range, an even split between male and females, a number of cohabitants, and then again their income. And we used this to be able to look at whether or not income related to how much people were willing to pay. You need to be aware that 100,000 of the Mongolian turgorids are equivalent to about $35 US. This was a particularly motivated group because of the 50 households, 40 of those households actually reported having a child who had been burnt in previous years, including some that were sufficiently seriously injured that they needed to be an inpatient. The qualitative data is obviously quite dense, but here's some of the top line messages. And you will see from that most of them felt it was an extremely positive outcome. They liked the design. They found that visitors were very interested in it. Where did it come from? How much did it cost? but generally very positive about the fact that they felt it made a difference in terms of risk to children, but also in terms of how they were able to manage childcare and not have to spend quite so much time constantly warning the children to avoid the pot. There were some design features that they requested we thought about, all of which were quite sensible, that we then used in the later follow-up for them to prioritise. So all in all, they actually thought that it was a good thing. Things like rounded corners, very sensible, wider feet, covering the lower rack were all ideas that we were willing to take on board. In terms of how much they were willing to pay, the average here at the top equated to about 37 American dollars. And that stayed pretty stable both now and later. We've split it here between their incomes, between whether or not they'd had a child who'd been involved. They weren't significantly different, although again, how much you earned did influence whether or not you were willing to pay a bit more. 10 months later, we went back and asked them for their long-term evaluation. Now, 6 families had stopped using the stove, and that's worth bearing in mind, because they had changed to using a winter stove, which is central to the care. And there were unfortunately 2 burns reported, although the rack wasn't involved in either of them. And one of these was unfortunately very serious. In this case, they had returned to using the pot on the floor, and it certainly brings up the question of how you maintain the long-term behaviour change and long-term support that might be required. One of them had actually had an accident involving the stove itself. As I noted earlier, the willingness to pay actually was pretty stable. The modifications that they were particularly interested in was the enclosure of the lower section, and we certainly agreed with that. In some instances, the children had used them to put their toys into the lower section or try to climb into it, so that was definitely thought to be a good idea. And they wanted an opening in the top section where the flex could more easily sit and link to a PowerPoint. And of course, rounded corners, and anyone who's been a parent knows how important that is. We also then showed them the design of what it would now look like if we took all of their comments on board, and this is the final design that we came up with. The focus group comments, again, remain very similar. Loved the rack, thought it was very beneficial, but they did pick up on the fact that ongoing support would be very useful, so that in any rollout we might allow that to become part of the programme. One thing that was an omission on our part is we didn't stress strongly enough that the rack would not get hot if it was placed next to the winter stove, which was the reason why the families in some instances had chosen not to use the rack over the winter. The rack actually stays at the same temperature all year round. What was interesting, though, was the visitors over that 10-month period had again asked questions about where could you buy one, how much did it cost, and again had noted the change in parental behaviour with that safety element. So, lessons learnt. It's a relatively small change in some instances, but it seemed to have a big effect. So even small changes, though, do need a lot of preparatory work, and the need for local knowledge and cultural sensitivity cannot be stressed enough. It took us several goes at a prototype, and we certainly needed a local team to conduct the work. And unfortunately for us, COVID hit during this project, which meant that all of the study was completed remotely. We were not able to visit during this time, but it shows things can work. Now, to get this to be rolled out, we need a government or health policy change, and that's going to be much harder for us to work on and help to happen. Here are the 2 publications. Both of them are in Burns, volume 48, if you'd like to look those up and find out some more details. So thank you for your attention. Small changes can work, but it takes a lot of motivation and take a lot of enthusiasm. As we say in Interburns, let's go on and make it happen, because tomorrow is too late. Thank you.
Well, thanks very much, everybody, all the speakers. And what we are now going to do is go on to our question and answer session. We have 3 questions already, but before we start answering them, I would like our team to put up a poll, which I would like everyone to participate and interact with, please. So, Natalie, if you could help us with the first question, there you go. In your opinion, what would have the most influence on a caregiver's behavior in preventing burns in their children? Only one response, please. And you can click on your screens. Hosts and panelists cannot vote. We'll give you a few more seconds, and then we will go on to the second question. Right, Natalie, when you're ready. There we go. All of the above are important, which is the 47%. Although we do have a split between access to healthcare and first aid knowledge, cultural beliefs, and household routines, which is 16%. And Orlando might want to pick this up when he's summarizing it as well. Okay, let's move on to the next question, please. Natalie, thank you. Which factor is the most effective in families adopting a safer home practice? Perceived risk of burn injuries, cost or availability of safety equipment, influence of school or daycare education, support from local health workers, or none of the above? Only one answer, please. We'll give it 1 second and then move on to the next one. Do participate, please. Yep, perceived risk of burn injuries. Very good. That's like your awareness. Cost or availability of safety equipment is for the next. And then the influence. So we've got, oh, somebody says none of the above. That'll be interesting to discuss. Thank you. Let's move on to the next one. Okay, so which type of message is most effective in changing behavior to protect children? Just one choice. Emotional stories from survivors, simple visual safety instructions, data-driven facts and statistics, messages endorsed by local leaders, all of the above, or none of the above? So we'll give it 1 more second and move on to the results, please. All of the above. Great, that's 52%. And we have some varied answers too. Right, thanks very much, everybody. And we will now move on to the question and answers. Our first question in the Q&A is the great rehabilitation, great PowerPoint. Rehabilitation is critical for people who acquire some form of disability due to burns. How can we make the link between burn and rehabilitation in health systems so that within the health system, patients are treated and rehabilitated into the community? That's a fantastic question, Dr. Kwambu. I guess today's session is more on primary prevention, and tomorrow will be your chance to address this question again, because tomorrow's session is going to concentrate on the secondary prevention and rehabilitation. But what I can say is, just as you have seen the involvement of the healthcare professionals, the training of the professionals, making the local teams aware that rehabilitation is just as important as preventing the injury, you can then engage the community and rehabilitation programs as well. I hope that has answered your question. And I hope that you will join us tomorrow for the session that will be addressing this in more detail. Orlando, do you want to take over the second question, please? It's from Dr. Robayo. And it says, in the case of burns in children in Colombia, we have a shameful phenomenon of children being burnt in the context of gender-based violence against their mothers. Could you share with us if you have any experience in preventing this in your countries? I'll pass you over to Dr. Orlando Flores to answer this question.
Yeah, well, unfortunately in Chile, we do not have so much experience dealing with gender-based violence. But I think that if you look at all the presentations has been sharing, probably is about changing behaviors. And for changing any behavior, it is important to have a strategy. So first of all, following Carmina's advice, know the problem very well. So what is the magnitude of the problem? What is the root of the problem? What is happening in the society that this is kind of common, or in some communities it is acceptable? Are you going to try to educate the people? Are you going to need to educate the people and also try to promote change in legislations, change in rules, trying to educate children in the schools to avoid this kind of phenomenon? And I think that as we with understanding a little bit the data and the evidence, most of the answers are in your local community. So probably it could be a very good idea to try to understand the phenomenon very well, to understand what causes that reaction is in the people, and trying to design a strategy to prevent in any other case of burns. And I think that is to your case. Carmina.
Yes, just also I want to say that I think that violence is one of the major social determinants of health, and perhaps we need to anticipate this, and probably from Colombia can help us with that next time.
Absolutely. It's
Another countries, of course, and another places.
Yeah, and it is a very probably it's a topic that is not that well explored, and probably is something that we should do in the future, for sure. Yeah. Thank you very much for the
Absolutely.
question, ID. Yeah.
Thanks very much for that. And we have one last question, which is very clinically oriented from Dr. Chowdhury, asking for importance of burn dressings, primary burn dressings to prevent further complications. Now, again, today's session is very much about prevention of primary burn injury in children. But as a clinician, I can tell you that we do not use topical local anesthetics. The large body surface areas involved can cause toxicity. We in the United Kingdom, we do not use broad spectrum antibiotic ointments, but we tend to use antimicrobial agents, and this is very much something that will be covered tomorrow as well. And I think Dr. Vinita Puri is answering this question. Vinita, do you want to unmute yourself? And yep, it is going to be addressed by Dr. Yvette Icasa on tomorrow. That's so perhaps you want to join us in tomorrow's webinar, and that will be really good to have you on board. Thank you very much. Have we got any further questions? If not, there's one more. Let me just check. No, not really. So I'm going to pass you over to my colleague Orlando Flores for summarizing today's event. And thank you so much for participating. It has been a fantastic webinar, and I hope you have enjoyed it. Orlando.
Thank you very much, Mamta. Well, first of all, I would like to thank our four amazing speakers, Claudia, Carmina, Regina, and Trisha. They all have done an amazing job. First, setting the context of the importance of preventing burning in children, and then showing us some experience on how to do it from different point of view. I am very grateful that they all um, prevention strategies that are fitted to the local context, and that is something that is actually very, very important. So we entitled this session Protecting Child's Future, Changing Minds and Preventing Burns. We were talking about changing behaviors. We were talking about how we can actually modify the risk factors and what we have learned today. First, burn injuries to child affects their entire life. So we know from Claudia's experience and we know from our own experiences as well that preventing burns is protecting children's future. So that is something that we should dedicate more attention to. And probably that is a challenge for all of us. We are probably all busy with clinical work. We try to do as much as we can, trying to treat burns properly, but solving the inequalities and solving the problem of burns as a public health problem probably is much more about doing prevention, concentrating efforts in prevention, and this is something that we wanted to discuss with you today. Also, there's challenges of burn injury in childhood that evolve over time, and burn survivors need support. It is very important to share with them that it's okay not to be okay, that seek timely support and change a negative experience into something that it is it is and with the help of the community. I think that this is not a journey to walk alone. It's something that we need to address as a social thing, as a community, and that is something that we would also like to share with you. The third point is that information is pretty much everything. Collecting local data inform behavior that lead to burns. So having systems to collect data is the first point, the cornerstone for designing prevention campaigns, for educational projects, as uh, our speakers has shown during the webinar. This is something that is absolutely important. If you don't have a good system of data collection, please, ourselves, our speakers have some experience doing so, and how to transform that information into something that is actionable for doing prevention, focus specifically in children. So this is something very important because burns are not accidents, are consequence of inequalities, social determinants of health. They are preventable and we can work on it. And finally, engaging community, families, public health initiatives, governments, policymakers, researchers, healthcare professionals is absolutely important to make some changes. So small changes lead to big impacts, and we really think that together we can prevent burns in children. So I would like to thank everyone for joining today's webinar. We have been delighted to organize this session. Again, we're very, very grateful for our four wonderful speakers for sharing their experience with us. And I would like to remind you that the World Burns Week is still going for the rest of the week. We have 3 more days of webinars in 2 time slot. The first one is 13 to 14 UTC, and the second time slot is 1 to 2 UTC. So you can choose the time that is more comfortable for you, but please join us because it is very important to sustain this discussion over the week and project these ideas on the whole year. In case you need a certificate of attendance, please feel free to scan the QR code that we are showing in the screen. You will fill out the feedback survey when you leave the session. This survey will come to you. You can then ask for a certificate of attendance, so please feel free to do so. The survey is very important for us, having some feedback on the organization, on how we can improve this for the next year is also very important. So thank you very much for helping us with that. And if you are still not on for the next couple of days of the World Burns Week, there's a couple of QR codes, one for signing up for the webinar series. We have Wednesday, Thursday, and Friday in this week, full of great conversations again. So please join us, because this is very important. And if you want to organize a local activity, it is also important for us to know that there are some other things, local activities happening all over the world, and we are very grateful for the support that the World Burns Week is getting from all our audience. So thank you very much for being with us today. I think that we ran a little bit late this session. Please save the date for next year. We need to remind ourselves that the first week of November will always be World Burns Week, and this work, doing advocacy, joining together, sharing our experiences is very important for the burn survivors, for the burn community, for us clinicians, researchers, and policymakers alike. It is important that we push forward for World Burns Week. So thank you very much for joining us this night for me, this morning for you, from the different countries you are joining us. So thank you very much.